Hi everyone, good morning. Welcome. Thank you for joining us today. I'm Ms. Kritika Selvakumar, lecturer, Department of Physiotherapy, M. Khandaya, Faculty of Medicine and Health Sciences, University Tunku Abdul Rahman. I'll be moderating today's webinar titled The Sensing Brain, Stroke, Diagnosis and Management by Dr. Peter Allen Akewitzon. The Mind Your Brain series is jointly organized by Malaysia Mental Literacy Movement with M. Kandaya, Faculty of Medicine and Health Sciences, Faculty of Science and Center for Research on Non-Communicable Disease, University Tunku Abdul Rahman. Dr. Peter Allen, MD, FPNA, is a vascular neurologist, medical specialist too from Department of Neurology, Baguio General Hospital and Medical Center. He has completed his medical schooling at St. Louis University School of Medicine and residency at Horse Rees Memorial Medical Center, Manila, Philippines. He has also got fellowships like Stroke and Neurovascular Ultrasound Fellowship from Horse Rees Memorial Medical Center, Manila, Philippines, Vascular Neurology Fellowship from University of Tennessee Health Science Center, Memphis, Tennessee, USA, and also faculty at St. Louis University School of Medicine, Pine City College of Medicine. Dear participants, if you have any questions, please type them in the chat box in your Zoom control panel. I'll bring them up during the Q&A session at the end of the webinar. To all Utah staff and students, kindly sign in your attendance in the link posted in the chat box. Now, without further ado, let's turn our time over to Dr. Peter. Over to you, Dr. Peter.
Okay. So, good morning. My name is Dr. Kitasol. I'm from the Philippines, and I'm here to discuss on stroke, recognition, diagnosis, and treatment. So, let me start by introducing what stroke is. So, what is stroke? So, stroke is a clinical syndrome consisting of rapidly developing clinical signs of focal disturbance of the cerebral function secondary to a vascular event. So, meaning it is a neurological deficit that would arise from a sudden problem in the vasculature of our brain. No? So, stroke constitute a major contribution to the morbidity and mortality of both developed and developing countries. So here in the Philippines, stroke is the second leading cause of death. No? It has a prevalence of around 0.9%, and ischemic stroke comprised around 70%, while hemorrhagic stroke comprises of around 30%. An average crude death rate of around 5 per 1,000 population due to stroke has been recorded here in the Philippines between 2003 and 2005. So how does stroke happen? So stroke usually doesn't happen for no reason. So we have risk factors that would cause or lead to a patient to having a stroke. So we would divide these risk factors into modifiable and non-modifiable risk factors. So for modifiable, meaning we can correct these risk factors, they would include hypertension. So around people with hypertension, around 20% of them would have a stroke. We also have diabetes, atrial fibrillation, dyslipidemia. We have smoking, tobacco. We have a sedentary lifestyle, patients who have kidney disease, who have sleep apnea, who take alcohol, and poor diet. No? For the non-modifiable risk factors, we have the male gender, genetic susceptibility, and age. So what are the subtypes of stroke? So we have two types of subtypes of stroke. So we have the hemorrhagic stroke, which is the rupture of the blood vessel leading to the leak of blood into the brain tissue. And we have ischemic stroke, wherein there would be a blood clot that would be lodged on one of our vessels that would cause a cessation of blood flow to that area. Hence, there would be lack of oxygen in the brain. So how do we recognize stroke? So we have this acronym that is commonly used worldwide. We have BFAST. So if a patient or an individual would have a sudden loss of balance, there could be a problem in vision, there could be facial droop or facial asymmetry. The patient could present with arm weakness or slurring of speech. So we use the acronym BFAST, and the important thing here is T for time, that we need to bring this individual to the hospital immediately. So in the hospital, we would do neuroimaging, either in the form of a plain cranial CT scan or an MRI. So these are example of CT scans that would show an occluded blood vessel or early signs of stroke. So we also do an MRI, which is more sensitive during the early phase of a stroke. If we see this white in the brain, or we call it as hyperintensity in this DWI sequence, this would denote areas for stroke. In terms of treatment for stroke, so it should be fast. So why do we need to rush the patient to the nearest hospital when we are have patients who are experiencing a stroke? No, so we would always hear this saying that time is brain. No, so when it comes to stroke, time is brain. So in a study done by Saver back in 2006, they noted that the patient who comes in with a stroke would approximately lose 1.9 million neurons, no, per minute. If there would be a delay in the stroke management, per hour, that patient could lose at around 120 million neurons. No? So we have approximately 86 billion neurons. So per stroke, if left untreated, or there would be a late treatment for the stroke, we would lose a lot of neurons. No? So just as a background, no? So our brain would usually have a cerebral blood flow of approximately 55 per ml per 100 gram of brain tissue. So during a stroke, we have a threshold of around 23 ml per minute per 100 gram. During this blood flow, there would be an isoelectric failure of our neurons or our brain cells. During this time, the brain cell is either functioning but is not yet dead. No? So it's still reversible. But if the blood flow would be below 12 ml per 100 gram of brain tissue, we could no longer save that particular area of the brain. So it would be an infarcted brain. So what are the main principles for acute stroke treatment? No? So we should achieve a timely recanalization of the occluded artery and reperfusion of the ischemic tissue. We should also optimize collateral flow, and we would prevent secondary brain injury. So recanalization and reperfusion are the mainstay of acute stroke treatment. Recanalization, it is defined by the degree of reopening of the occluded artery, and reperfusion is a measure of the degree of flow reaching the previously hyperperfused brain region. So the pathology or the pathophysiology of stroke is when one of the vessels of our brain would become occluded. So our main goal of treatment is to open up that vessel again. So opening the occluded artery works because in most cases, when the occlusion occurs, an area of brain tissue becomes hypoperfused but is not initially infarcted. So meaning there would be lack of oxygen for some time, but the brain won't be infarcted or won't be dead, no, during that time. No? So we're trying to save that area, and this area is represented by what we call as the penumbra. So if you look at this diagram, so in the area of an ischemia, there is this central core, which represents a markedly reduced cerebral blood flow. And surrounding that area, this orange color would be the ischemic penumbra. So this ischemic penumbra is the tissue which is functionally impaired and is at risk for infarction, and we need to save this area. So with when the patient comes in, like in the hospital, this area would represent the area, or would be the symptomatic side. No, if the area would be on the left side, the patient would present with probable right-sided weakness. No, so we want to save this area. No? So how do we do that? No? So there are two evidence-based strategies to achieve reperfusion. One is by chemical thrombolysis with recombinant tissue plasminogen activator, or your RTPA, also known as your alteplase, and by mechanical thrombectomy. So these two methods would try to open up the vessels either by chemical or by medicine. We try to lyse the clot, or by mechanical thrombectomy is an invasive procedure wherein we try to get the clot out from the blood vessel. Another important thing to consider during treatment is the collateral flow. So it is responsible for keeping the ischemic penumbra viable. It provides enough flow to prevent critical ischemia and infarction, but not sufficient flow to maintain normal cellular function. So this explains why the acute neurologic deficits exceed what would be expected for the established infarct core at the time of presentation, and why neurologic function can improve after reperfusion. Collateral flow, however, is often tenuous and can sustain viability only for a limited period of time. So we need to rush the patient to the hospital because time is really brief. Without recanalization, the ischemic penumbra is destined to progress to infarction. So how do we protect the collateral flow? So when we bring the patients, we do certain maneuvers, like we avoid blood pressure drops during the acute phase of stroke. We would administer fluids. We would keep the head of the bed flat for patients with acute stroke, which would in a way increase cerebral blood flow to that area. We would hemodynamic augmentation with vasopressors can be beneficial in selected cases. We would avoid hypoglycemia or drop of sugar, which can exacerbate energy failure and should be strictly averted. And we also avoid fever, which is associated with worse clinical result and outcome. So what happens during a stroke? No? So what is the recanalization rate? So what are the chances of the blood vessel opening up? No? So if we do not do anything, 24.1% chance the vessel would open up on itself. No? So, but if we give your RTPA, your intravenous thrombolysis, the chances of the vessel to open up would be doubled to around 46.2%. If we do intra-arterial thrombolysis, like for example, we insert a catheter and inject the RTPA directly to that occluded vessel, would increase the recanalization rate to around 63.2%. And if we do both the chances of it opening up would increase to around 67.5%. But if we directly take out that clot, the chances of it opening up is very high at around 83.6%. So there is incontrovertible evidence that IV thrombolysis with RTPA and endovascular thrombectomy with a retrievable stent improve neurological outcome in patients with acute ischemic stroke. These treatments should be administered as quick as possible after the onset of stroke and can be combined and are safe in appropriately selected candidates. IV thrombolysis and mechanical thrombectomy can produce reperfusion injury after recanalization, and reperfusion injury can manifest with hemorrhage and edema. So there might be complications, but the benefit would always out risk, no, in giving treatment for our stroke patients. So IV thrombolysis with RTPA is proven to be effective in improving functional outcome after an ischemic stroke up to 4.5 hours after symptom onset. If you look at this slide again, so we would be able to maximize treatment and give the most excellent outcome if we would treat the patient within 4.5 hours from the onset of stroke. So the earlier we treat the patients, the better the outcome for our patients. So always keep that in mind. The earlier we bring the patients to the hospital and we give appropriate treatment early, we would expect an excellent outcome for our patients. So this is just a slide that tells us that alteplase or the RTPA is better among patients. No, if the treatment is given in less than 3 hours, the outcome would be better. No, the longer we give the treatment, the less beneficial for the patient. As far as age, it is noted that it may be a better outcome for young patients, but considering both, it would still be beneficial for patients less than 80 or more than 80 years old. So RTPA or your intravenous thrombolysis administration is approved within 4.5 hours of stroke onset. The initial evaluation of a patient with a possible acute stroke in the emergency department should focus on establishing whether the patient is eligible for reperfusion or not. So we would really try to find the indication to give this treatment to our patient. No? So what are the information should be provided when we bring patients in the emergency room? No? What is important is we know what time did the stroke start. No? So it's a very important information that we should know. If we are unable to determine the exact time for the stroke onset, we could determine what time was the patient last known well. So when was the patient normal or did not have any symptoms? What are the medical conditions of the patient? Did the patient have any recent surgery? We get the glucose, we get the blood pressure, and then we get the CT scan and an angiogram. So the NIH score is just a tool to help us gauge how severe the stroke is. So IV thrombolysis should not be withheld because of advanced age and mild but disabling deficit. So by experience, the oldest patient that I gave thrombolysis is around 99 years old and still had an excellent outcome. We could also give RTPA for mild but disabling deficit. What are these disabling deficits? For example, for drivers who would present with blurring of vision, once this blurring of vision is not reversed, no, that patient can no longer work. for example, also our lawyers, like if they would present with slurred speech, if we don't correct the slurred speech or treat the slurred speech due to a stroke, that would pose problem when they do have, like when they work. No? So IV RTPA infused within 3 hours of symptoms onset increases the chances of functional independence at 3 months by 1/3. So 30% of patients who receive RTPA within like less than 3 hours would have an independent outcome. No? So they would functional independence. So you would be able to do their daily activities without any assistance. The benefit is time dependent and much stronger when the medication is administered within the first 90 minutes after onset of stroke. No? So time is really important in stroke treatment. So this would just show us that the earlier we give the stroke, the medication for our stroke patient, the more benefit no, they would have. And then if treatment is delayed, this would show us that there would be more harm. It would give more harm to our patients than benefit. So the earlier, the better. No? So there are certain indications for giving RTPA. No? We have our Heart Association as well as the FDA indications for RTPA. Basically, they are given early. So we usually use the cutoff of 4.5 hours. It can be given also with patients who just woke up with any stroke symptoms, patients who would have stroke with disabling neurological deficit, and it would be given more or less for patients more than 18 years old. So there are certain contraindications. This information is also important for us to know when the patient is brought to the hospital. Did the patient have any recent trauma or recent stroke? Did the patient have any history of hemorrhagic stroke or bleeding type of stroke, or any heart problems? So this is very important because once they are present, they could be contraindications in giving the medication. So again, these are other contraindications. We have to control the blood pressure. Are this patient taking any medications? Like for example, heparin or warfarin, or any bleeding problems in the past as well. So older patients and those with a very severe stroke at presentation have worse prognosis but can still benefit from our IV RTPA. The benefit is less robust for patients treated between 3 and 4.5 hours, but RTPA is still beneficial in this extended window. So again, the eligibility, usually we give these medications for patients 18 years old and above who have clinical diagnosis of stroke, and the onset of stroke symptoms is less than 4.5 hours. So again, a review of the contraindications. So this is the standard dose of RTPA. We give it at 0.9 milligram per kilogram, and we administer 10% of the computed dose as a bolus, and the remainder would be given or infused over an hour, and the dose is usually not more than 90 milligram. So so again, as mentioned earlier, we have the NIH score. This is a neurological tool quantifying the neurological impairment. So it would tell us how severe the stroke is, and this is a tool to measure, or it enables the healthcare provider to rapidly determine the severity and possible location of the stroke. So the higher the NIH score, the the severe the stroke is. No? So we focus on these areas when we do the NIH scoring for our patient, and the highest score is 42. No? Patients with minor stroke usually have a score of less than 5. A score of greater than 10 correlates with an 80% likelihood of a big vessel that was occluded. So this is an example of our NIH scoring. So this is the timeline that we should try to achieve in treating stroke patients that comes in the emergency room. No? So once the patient would arrive at the ER, no, it would take less than 10 minutes for the physician to be able to assess the patient. And then in less than 15 minutes, the neurological team, or the patient should be referred to a physician with special training in stroke management. We should be able to do the CT scan in less than 25 minutes and be able to interpret the scan in 45 minutes. And our goal is to be able to give the treatment in less than 60 minutes once the patient arrives at the ER. It doesn't mean we maximize the time. So the earlier, so by experience, the earliest RTPA that we were able to give was within in less than 10 minutes. Less than 10 minutes, we were able to administer RTPA. So we monitor the following once the RTPA is given. So we check for severe headache. We note for the acute hypertension or elevated, extremely high blood pressure, any signs of nausea or vomiting, or worsening of the patient's condition. When this happens, we obtain an emergent CT scan. So we would measure the blood pressure regularly, around 15 minutes for the next 2 hours, and 30 minutes for the next 6 hours, and hourly for the next 24 hours. So we monitor again, as mentioned earlier, the blood pressure. We don't insert any NGTs or any catheter once the RTPA is given. And we would get a repeat scan after 24 hours when the RTPA is given. So the most common complication with RTPA is bleeding. So the bleeding risk is around 5.6%. So if we would give RTPA to 100 patients, around 5 to 6 patients would have bleeding, which can be minor. And around in these 5 to 6 patients, around 1 would have a severe bleeding. So again, the complications is bleeding. For the symptomatic intracranial hemorrhage, that would be around 1.9%, around 6.4%. No? So most cases of symptomatic bleeding is caused by reperfusion injury that were already severe and destined to be disabling. No? So the bigger the stroke is, more or less it can probably increase the risk for bleeding, but it doesn't mean that we would withhold the medication. A big factor for this is the earlier the treatment, the less bleeding complications the patient would have. So what are the risks for bleeding? We have age. Patients who have diabetes, who has severe hyperglycemia or elevated glucose, patients who have uncontrolled hypertension, and the presence of cerebral microbleeds. So we would treat if ever the patient could have complications of bleeding. We get an CT scan and we try to reverse the effect of the RTPA. So there could be hypersensitivity as well for the patient. So the limitations for giving RTPA, it has a short time window, which is just 4.5 hours. It is contraindicated in patients with increased bleeding risk. And IV-RTPA often fails to recanalize proximal artery occlusion. So patients who have a large clot in large vessels, more often than not, RTPA is unable to lyse this big clot. No? So during this time, there is a strong evidence that patients should be considered for endovascular therapy, or we try to manually take out that clot. No? So given this, no, so endovascular mechanical thrombectomy must be considered the standard of care for patients with disabling symptoms caused by acute cerebral ischemia related to an occlusion of an large artery. No? The value of mechanical thrombectomy is supported by multiple randomized controlled trial and shows substantial improvement in functional outcome with this treatment. The number needed to treat would be 3 to 7 across these trials. So if we treat 3 or 7 patients with thrombectomy, one patient would have an excellent outcome. So again, this would show us the benefit of patients who would undergo a mechanical thrombectomy. These are the different trials, all showing that mechanical thrombectomy is really important. Okay. So next, again, these are the trials. No? So big vessel stroke would benefit from mechanical thrombectomy. So these are the candidates, no? Patients who have a large stroke, more than 18 years old. It can be done in patients having a stroke that was brought to the ER more than 4.5 hours. No? So again, so when the patient comes in, we do CT scan and we check the vessels, and if there's an evidence of an occluded vessel, then we do endovascular thrombectomy. So this is an example of one of our actual patients when I was a fellow. If you look at this part of the screen, so this is the large vessel, and if you look at this, there is a cut off of that blood vessel. No? They did a thrombectomy and removed the clot, and if we look at the second study that they did, we could see the vessel that was reperfused. No? So from no vessel at all, when we remove the clot, the vessel would be recanalized and would provide blood flow to that area of the brain. So there are also special situations that we should take note of. No? So we have patients who would come in with wake-up strokes, no, or we don't know the onset of the time of the stroke. No, probably this would come in when we see patients who would be seen in the sidewalk, for example, with stroke symptoms, and there was no witness. No, so neurologic deficits are first noticed upon waking up, would represent a particular challenge to the clinician. It is unclear, or the time of onset is unclear, and it is an unwitnessed stroke. No, before, when I was training, it was contraindicated once we don't know when the stroke started. Usually, it is a contraindication in giving RTPA. But there are a lot of trials that have shown that in a way we could estimate, no, when the stroke started. No, this would also, we could also request for a mismatch. No, we have technologies to predict how big the penumbra is compared to the ischemic stroke or the infarcted core. No, so we have the CT perfusion that we can use to predict if the stroke penumbra is still big and can be saved Hence, the patient would be a candidate for thrombolysis. No? So diffuse 3 trial, no? We have extended treatment to more than 16 hours. So for wake up stroke, no? So for patients who woke up with stroke symptoms, we can get an MRI. And with the MRI, we can predict that the stroke may have happened in less than 4.5 hours. So there are certain instances when patients who are on an anticoagulant or a strong blood thinner and would present at the emergency room with stroke-like symptoms. No? So we would need blood tests to see how um, thin the blood is. No? So if it is thin and is too thin, then we won't give RTPA. No? So this is also a controversy. What if the patient would come in initially with a severe stroke and then for some reason they would improve on their own? No? So do we give RTPA? No? So what we look for is not how fast or rapid the deficits are, but rather if these deficits are disabling. No? If the deficits are disabling, and then it is a justifiable reason that we give RTPA. No? So per strokes at the back or the posterior area of our brain or the back area of our brain, so we still give RTPA, and then our patients would have a good clinical outcome. No? We also do stroke rehabilitations for patients who had a stroke. No? So any aspect of stroke care that reduces disability and promote participation in activities of daily living. No? So the objective of stroke rehabilitation is to prevent deterioration of function and improve function, and we want to achieve the highest possible level of independence for our patient. So these are the stroke rehabilitation. No? So the human brain recovers from stroke in three major ways: adaptation, regeneration, and neuroplasticity. No? So other parts of the brain would try to compensate or take the role of the area where the stroke is. The brain would also try to regenerate and replace the damaged area. And neuroplasticity, the brain tries to rewire itself so that the brain would be able to function and compensate for the stroke. So most stroke deficits will see the highest rate of recovery during the first 3 to 6 months after a stroke. So therapy is important, not just during the patient had a stroke, but also is important after the stroke. The patient would until 6 months after the stroke. No? So treatment initiated within the first 20 days was associated with a significantly higher probability of excellent therapeutic response compared to treatment beginning after 20 days. No? So a goal of stroke rehabilitation should be facilitate the relearning of skill that were possible before the stroke. No? So we have types of therapy. We have physical therapy, which is more in movement and balance. We have the occupational therapy, which would help survivors learn strategies to manage daily activities such as eating, bathing, dressing, writing, and cooking. And speech therapy, which would help stroke survivors learn strategies to overcome swallowing and language deficit. No? So rehabilitation is a process of stroke care that reduces disability and improve participation in therapy. Recovery is defined as improvement across a variety of outcomes. So conclusion, so acute ischemic stroke is a medical emergency in which every minute would count. Achievement of reperfusion can reverse neurologic deficits, even if severe, and allow patients to regain function. There are two reperfusion strategies. We have uh, by medicine or chemical, your IV R3PA, and your mechanical thrombectomy. Patient selection is crucial to optimize outcome, and the attitude of the clinician should be treatment should be given unless a solid evidence of contraindication would exist. Okay, so this was taken when I had my fellowship. So we had a big ambulance who has a CT scan in the ambulance. No? So we would bring the CT scan to where the patient is to reduce the time for treatment to be given. So this is the stroke team when I was a fellow. This is my boss who taught me about stroke. I think so. As final words, no stroke. We think globally and we act locally. No, stroke is a brain attack needing emergency management, including specific treatments and secondary and tertiary prevention. Stroke is an emergency where virtually no allowance for worsening are tolerated. Stroke is treatable optimally through proven, affordable, culturally accepted, and ethical means. And importantly, stroke is preventable in implementable ways across levels of society. Thank you for your kind attention.
Thank you, Dr. Peter, for highlighting us about the symptoms, the prognosis, and everything. So now let's move on to our Q&A session. I just remind the participants kindly type in your questions in the chat box to our speaker. We already had one question, Dr. Peter. The question was, what are the symptoms of stroke?
So as mentioned earlier, so we use the acronym BFAST for us to be able to remember. No? So we have B, the patient would lose balance. No? The patient is usually unable to walk or would fall for at one side to one side. We have eye problems. We have vision problems, either in the form of blurring of vision or doubling of vision. The patient can see doubles. No. F, we have face. We look at the face. Usually there is a facial asymmetry or drooping of one side of the face. We have A, arm weakness. No? The patient would present with arm or leg weakness. No, usually it's seen at one side of the body. S, we have slurring of speech, which is also common. Our patients would have slurred speech. No, at times patients would have problem talking or understanding spoken language. So these are the common symptoms for stroke.
Okay. Thank you, doctor. I do have few questions. Before I again remind participants, please type in your questions in the chat box. Question from my side to you, Dr. Peter. When do you do recanalization and when do you do reperfusion?
Okay, so it would depend who you ask. No, either you ask the endovascular surgeon or the neurologist. No, what we all usually do is when the patient comes in and the patient is eligible for like thrombolysis for the medical treatment, is we give the treatment. No, and then we don't wait for the endovascular people. No. And if we do the workup and we see a large vessel that is occluded, then we refer the patient for thrombectomy. No? We still give RTPA because more often than not, when we call the endovascular team, they are not yet in the hospital. No, for us to be able to give quick and early treatment, we give thrombolysis and then we send the patient to the cath lab. But for patients who would come in and their stroke symptoms is already more than 4.5 hours, then those patients are no longer eligible for RTPA. So we send them directly to the cath lab for possible thrombectomy.
Okay. Thank you, Dr. Peter. There is a question from participant. What are the effective ways for helping a stroke patient to regain the speech?
So for the speech, no. So the for in my opinion, the most crucial in treatment for stroke is the recognition. No? So that's the very important thing. If we don't recognize stroke early, so everything would be delayed. No? And if we delay treatment, then outcome would not be that beneficial, or the patient's outcome would be poor. No? So for slurring of speech, when we give the treatment early, or if we recognize symptoms early, we give early treatment, the outcome would be good or excellent. The earlier, the excellent the treatment, the earlier we give treatment, the excellent the outcome is. And then post stroke treatment, then we could refer the patients for either speech to the speech therapist for speech therapy.
Okay. Thank you, Doctor. Next question is, you mentioned about ENIHS stroke scale. So apart from this, do we have any other outcome measure which can measure the severity in patient with stroke?
Usually use the NH score when the patient is like in the hospital. This is a standardized tool. Uh, like for example, if I do my NH score and the nurse would do the NH score, more or less it would translate. It is a standardized tool. So if I do it and she do it, more or less the result would be similar. But when the patient is in the hospital, then we have the modified ranking scale as a tool to use to gauge how this how the patient how this severe the disabling deficit for our patient. No? So we have the modified ranking scale, and we as a gauge for how severe the deficit is.
Okay. Next question from our participant. How to control the use of warfarin for a heart patient after the surgery from brain stroke?
So usually, uh, if the patient would come in because of bleeding secondary to the use of warfarin, usually when the patient would be for surgery, so we do the surgery and then we ask if when it would depend really on the surgeon on when to resume, no, the anticoagulant. But when we are able to get clearance from the surgeon, if we can start warfarin, it will usually start at a low dose, no? And we try to determine what is the reason for the bleeding. If it is safe enough, then we start at a low dose, and when we titrate or we adjust the medication to achieve the INR of around 2 to 3, no, for our patients.
Okay. Thank you, Doctor. Next question is, maybe from your experience, what is the prognosis of hemorrhagic stroke and ischemic stroke?
By experience, so ischemic stroke is caused by a blockage of the artery. No? When that big artery is blocked, anything that is supplied by that artery would die. No? Given we are unable to recover the function for that area anymore. As for bleeding, the symptoms is usually more of a pressure symptoms. Like for example, if this structure of the brain is being compressed by the bleeding, it would result, for example, to a weakness. But over time, that bleeding would be absorbed by the brain itself, so it would shrink. When the blood would shrink, the compression or the compressive symptoms would also decrease, meaning that the patient might be able to recover more once the pressure symptoms is resolved. No? So we have a better prognosis in terms of functionality for bleeding patients compared to an ischemic stroke.
Okay, thank you, doctor. I remind again, dear participants, if you have any questions, kindly put that in the chat box. Next, one more question, doctor. The question is, how do we relate neuroplasticity and stroke? Is there any specific duration for this neuroplasticity to take place in a patient? Does it
So
differ with the age, gender, and all?
yeah, so neuroplasticity is new to neurology. No, by experience and by study, the younger the patient, no, the better the neuroplasticity is. The brain is able to compensate more when we are young. Like for example, we have like pediatric patients who have had injuries. No, they would recover better. No? They would tend to recover function better compared to an elderly who had a stroke. Recovery can be slow and it can be less promising compared to young patients. No?
Okay. Thank you, doctor. Next question is there a way to address the gene factor leading to stroke?
We cannot, it's part of the non-modifiable risk factors. No? So we cannot change our genetic makeup. No? If we have risk factors for stroke, that we are that is being inherited from our ancestors. No? What we could do is probably, so these genetic factors can be more severe if exposed to certain criteria. Like for example, if you have a history, a family history, for example, of hypertension, of diabetes, if we have like unhealthy lifestyle, uh, it can lessen the chances of us having this certain diseases. No, so we have still have to modify a certain area in a way to help alleviate, no, these risk factors genetically. So, but we would focus more on the modifiable risk factors, no, what we can measure and what we can control.
Okay. Thank you, Dr. Peter. So we just have few more minutes left. Participants, if you have any questions, kindly put them in the chat box. Maybe we just take up questions for another 2 to 3 minutes. Any other questions from participants? Okay, I think it looks like we have covered all the questions. Dr. Peter, is there anything else you would like to cover before we wrap up?
So, as a final word, no, so stroke is a disabling deficit, no? So the recognition, the early the treatment, the better the prognosis. Or and then more importantly, stroke is treatable and stroke is preventable. No? So hopefully, once we recognize stroke among the people that we know, we are able to bring them immediately to the nearest hospital, and the early the treatment again, the early the better the prognosis. Again, thank you for the invite.
Thank you. Great. Thank you, Dr. Peter, for this insightful webinar.